So what to expect from Mohs surgery, or any surgery for that matter? For Mohs surgery and traditional wide local excision, at least in the dermatology office, this setting is an outpatient-based procedure where folks are awake. They can communicate. Oftentimes during surgery, at least the reconstruction part, there can be music, and we kind of tailor the day to the patient's comfort level. But really, in terms of steps, it starts with informed consent. And my mentor, Dr. Dave Broadland, said it best: the informed patient with informed consent can make an informed decision. So whenever you're talking with your surgeon about what to expect and what are the alternatives to surgery, because there are alternatives and they have their own pros and cons with regard to cure rates and side effects and expectations for healing, it really starts with a complete understanding. And for people who want a little bit better illustration of the process, I welcome you to go to the mohscollege.org, where there is a patient portal that you can see a really nicely done video on the technique. And that's something I think really is helpful for patients who might be anticipating surgery. Local anesthesia is the hallmark of how we keep people comfortable. So the other benefit of doing these types of outpatient procedures is that we're not subjecting folks to general anesthesia. So usually this is done with mixing lidocaine 1% with some epinephrine, which allows us to limit bleeding at the site of surgery. It kind of shuts down the highways that bring blood to the sites that we don't have a field that is obscured by bleeding. And I think it's a little less, kind of disconcerting for patients and when we use it. And we also add sodium bicarbonate, which allows us to buffer our anesthesia to make the actual act of injection a little bit more comfortable. A lot of people with local anesthesia without buffering often find that it stings quite a bit, and that reflects the lower pH or the acidity of the solution. So most surgeons and dermatologic surgeons and plastic surgeons, if they're getting involved in reconstructive surgery after Mohs surgery, use this technique. And then finally, sometimes there can be mixed in with your solution a antibiotic, most often clindamycin, that really has helped reduce a lot of the post-operative infections that we see after Mohs surgery. But that being said, the risks of Mohs surgery or any skin surgery are quite low, less than about 1.5%, regardless of anatomic location, age, or other factors, yield an infection after surgery. And this is really mitigated by, really impeccable technique, making sure that the field is clean, sterilized. We use sterilized instruments. We also use sterile technique, at least with the reconstruction part, clean technique for Mohs Resection part. And then also, once you're comfortable and you're numb, we do the Mohs Resection part, and that's where a lot of the counseling about the day centers around the wait time, which is kind of, it's funny because we've really made tremendous advancements to be able to take our specimens, which we usually send out to outside labs for a biopsy. If anyone has had biopsies done, you'll know that it takes about 1 to 2 weeks to get some of those results back. And here we have condensed a lot of this processing real time into a period of about anywhere 60 to 90 minutes. And it's a little bit longer for the immunohistochemical staining that I mentioned earlier. But bottom line is, it's been really a revolutionary technique to be able to condense that information down into one day. And we usually counsel our Mohs patients to be prepared to spend the day, albeit we really don't find that that's necessary for most patients, because take, for instance, basal cell carcinoma. We may have one attempt and get it clear and then focus on what we're going to do about the wound and proceed to a repair or reconstruction or some other form of wound healing. Or it may take multiple attempts of Mohs surgery. We mentioned the precise mapping. So if we do have roots, we have to go back until it's clear. So with basal cell carcinoma, the national average is about 1.6, 1.7 attempts. So somewhere between 1 and 2 attempts in general is what's necessary to remove a basal cell carcinoma. And that follows suit for most non-melanoma or small skin cancers. But the day can be unpredictable. And I think, if you become prepared, that it's a lot more enjoyable and less uncertain.